The following video shares our approach to a unique situation for arthroscopic revision greater tuberosity fracture repair. Our disclosures are listed here. This was a 56-year-old right-handed male who came in with left shoulder pain after a ground level fall. X-rays obtained in the office demonstrate a displaced greater tuberosity fracture with extension into the proximal humerus, and after discussion of his goals and activity levels, as well as the displacement of the greater tuberosity, we elected to proceed with surgery. Initial surgery was completed, and he had open reduction internal fixation of the humerus with suture fixation of the greater tuberosity piece into the plate with postoperative films pictured here. Unfortunately, at his 10-day postoperative visit, there was redisplacement of the greater tuberosity fragment. Postoperative CT scan is shown here, coronal slices, which demonstrate redisplacement of the greater tuberosity fragment with posterior comminution. We discussed these findings with the patient, and he elected to proceed with revision surgery. We discussed technique options and decided we would do this arthroscopically to try and maximize visualization and suture placement, as well as allow for potential additional anchor placement. The following video demonstrates this technique. The surgery was performed in beach chair position. Viewing from posteriorly, we started with the subacromial decompression, which demonstrated tearing of the sutures out of the plate with the sutures at the musculotendinous junction. We started by resecting the excessive scar tissue in order to mobilize the rotator cuff tendon. A traction stitch was placed and the rotator cuff was able to be mobilized back to the footprint. Not shown in this video, we did place a double-loaded suture anchor anteriorly and pass this through the rotator cuff in horizontal mattress fashion. As you can see, there was a large bony defect which did not allow us to place any additional anchors due to poor purchase in the bone. We therefore elected to utilize the proximal humerus plate with holes that are made for suture fixation. We utilized the lateral portal and a suture passing device to thread the lasso through the existing holes and then subsequently pass heavy suture, starting with the most posterior hole that we were able to access, then the middle hole with 2 limbs of suture, and finally the anteriormost hole. We then utilize this suture passing device from the posterior portal to shuttle the sutures through the rotator cuff tendon from posterior to anterior. As there was the large bony defect shown previously, we elected to deliver some demineralized bone matrix into the area in hopes of reconstituting some of the greater tuberosity. At this point, the sutures were sequentially tied with arthroscopic knots in addition to the previously placed anterior anchor. As you can see here, after tying the sutures, the rotator cuff is well reduced back to the plate. Intraoperative fluoroscopy was performed, shown here, which demonstrates reduction of the main fragment back down towards the plate. Additionally, x-rays taken in the postoperative unit demonstrate adequate reduction of the main fragment of the greater tuberosity. Postoperatively, the patient was placed in a sling for the first 6 weeks with minimal motion. Starting at 6 weeks, the patient then progressed through passive, then active assisted, then active range of motion. At 12 weeks, the patient was allowed to begin a light strengthening program. Thank you for your attention.